Kita ada international ke, Syam?
Itulah tak perasan Mak.
Dia boleh mix ke, is it?
Boleh kot.
Okay, tak apa.
Okay, it's already 3:30. Boleh start kot, Prof?
Boleh.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera. Good afternoon, everyone. It's my pleasure again to welcome you all back today to our monthly simulation webinar, especially on this important topic. I think that's play a significant role, especially in patient safety and effective in medical teaching and learning, which is non-technical skills in airway management. Yeah. Before that, I would like to notify that towards the end of this webinar, I will flash a QR code for you to register to receive your attendance certificates. And if you have any questions, please type in the chat box and I will read up for you towards the end of this webinar, or you can ask directly to our speaker. Yeah. So today we are honored to have. Yes.
If we are using phone, we cannot scan our phone. So can the QR code be like in a what call in a URL so that we can also click instead of just a QR code?
In the URL, so let me think how to do that because I have in a PowerPoint.
I see. Okay.
Yeah. So maybe I can. Yeah. I have to think about it how.
Okay.
Okay. So let me introduce to our speaker. Yeah. Associate Prof. Dr. Hashairi is a distinguished expert, especially in this simulation field. Prof. Hashairi is a consultant, emergency physician at the Departments of Emergency Medicine, School of Medical Sciences, Health Campus, USM in Kubang Krian, Kelantan. He is also a clinical and research fellow at the Critical Care Research Group in Brisbane, Australia, and a WinFocus Fellow in Emergency and Critical Care Ultrasound. So, Prof. Ashari will provide us with a deeper understanding of this, we call it non-technical skills, yeah, on communication, on teamwork, decision making, and some situational awareness, just as critical as in technical skills, especially in managing airways effectively. So I think without further ado, please join me in welcoming Prof. Ashari to deliver these vital topics. So Prof, the screen is yours.
Okay. Bismillahirrahmanirrahim. Assalamualaikum and good afternoon, everyone. First of all, thank you so much, Prof. Hisham, for your kind introduction. Saya share slide dulu boleh ke, Prof?
Sure.
Okay. Nampak kan?
Yes.
Okay, wonderful. Thank you. Okay. Thank you again, Prof. Hisham, and thank you also for the MaSSH, Malaysian Society for Simulation in Healthcare for invitation. I think Prof. Ismail, Rosaneha, and few ESCO MaSSH member also here today. So thank you so much. So the topic that I opt for is about non-technical skill. So I guess most of us familiar with this term and familiar with the also airway, which is our forte in emergency department. So I will go a little bit after this why I choose a non-technical skill in airway management. And of course, this discussion or sharing basically is not a lecture. So maybe roughly about 20 or 25 minutes. So I wish, I guess also we have many SIFUs here in simulation could add on later, give their input and feedback about these topics. So of course, we are still in the mood of Merdeka Day, Hari Kebangsaan. So I wish everyone here, so selamat menyambut Hari Merdeka. So the bijak pandai have said before, hitunglah kesyukuranmu bukannya kesukaranmu. Okay. So to begin with, I just share when I did a search strategy, mainly for those who are familiar with the CCT review and also meta-analysis. When we use this is an example of PubMed. And we use this search strategy using a Boolean operator. So I put some keyword. I searched yesterday night. So if you look at a term here, for example, non-technical skill, which is also together with human factors. There is a difference between these two, but I just put to make it more broad searching strategy. So non-technical skill, the human factors, plus the soft skill, and airway management, emergency airway or intubation, and teamwork. Okay, this keyword like the teamwork, the communication, the awareness, the leadership, decision making is part of the non-technical skill term. So if you look at here, the research trend, actually, people look into this many years ago, but the exponential increase, especially during COVID time, and also, currently people looking at this non-technical skill component. So again, we understand that to be part of the successful airway management, even though we have new technology, the marvels, the airway devices and gadgets, we embrace with the technology, but we need to remember this human judgment. Okay, the human judgment remain a fundamental point of safety and quality. So why I choose the specifically about airway? So number one, of course, we are an emergency fraternity. So airway is the vitals for us. And when I do some search, what are the medical emergency frightened ER doctors and nurses the most? So basically the topic that have been discussed about the airway. So that's why I think airway, I choose the airway for today because of this important topic, as well as we also encounter, even though rarely we encounter some difficult airway, but sometimes we have also need to facing this kind of difficulties. So when we talk about the human factors and non-technical skill, of course, we look at the tip of the iceberg. So to successful managing the airway, so we need a few elements before we successful manage, especially the difficult airway patient. And if you look at it down there, the most important, we look at the element is the non-technical skill, but the human factors is part of the component that we need to improve ourselves when we managing this difficult airway or in general airway management. So if we go deeper, why the airway management is very important, especially we need to know the management of this, because we know that we are in the high risk condition as a healthcare practitioner. We are in the the component of the dangerous so-called job, and we could basically involve patient life. So healthcare consider one of the dangerous discipline that can cost our patient life, apart from other discipline. That's why we have to minimize a few things, not only for us but also for our patients. So again, the approximately 80% of clinical errors are due to human errors. Okay, this is based on Net4 report. So in UK, so they found that the most of the errors because of human errors, and reflecting that's rarely due to technical skill failure. So most of the errors because of non-technical skill. So discussion of human factors and non-technical skill is very, very important. I keep mention about human factors and non-technical skill. So there are two different things. Maybe some get as a different reference, but this is actually the accepted concept of the human factors. So if you can read here, the human factors in general, basically just to describe how human interact with various elements of system. If you look at here, we can have the equipment, the workplace, the task, the organization itself. So the non-technical skill is part of the human factors. Okay, so the interaction between humans and other element of a system, that's defined the human factors. So to explain further, I use this shell framework. I know we have other framework to describe about human factors, but for this discussion today, I just use the shell framework to describe. Okay, the shell model basically come from the aviation industry, whereby the conceptual model to help us clarify the location and the causes of human error within an aviation environment. Okay, so the interface between the central individual and the other aspect of the model is also important and they must be considered. So in general, if we look at the shell model, the shell model here consists of the software, the hardware, the environment, the liveware, and central liveware. The central liveware where actually us that's standing in the middle. So the interaction us between the software, the hardware, the system, the environment, and the liveware. I will explain further. So that's define the human factors. Okay, human factors. Okay, so when we go further, so describe related to us, how we define the software. So the software basically the guideline, the protocol, the checklist and pathway that we work with. Okay, specifically in Airway, so we have the Airway guideline. If you read further, we have a lot of guideline related to Airway management. And protocol, sometimes in our own institution have our own protocol and checklist. So this considered as software. And how about hardware? Hardware mainly all the technology, for example, or the Airway gadget, the monitoring and so on and so forth. How about the environment? Basically, environment is related for the patient and us. The workplace, basically the workplace, either the setup in the emergency department or we go to other ward to secure a patient airway, or for example, we respond for the code blue, we go to other ward. So this is the environment, the workplace. Is it how the condition that we facing when we are dealing with the airway in that place. And of course, the L is a liveware. Liveware is referred to the peripheral liveware, which is the team we work, which is our team, our assistant, our friends, our patient, relative, our staff. So this include under peripheral liveware. And the central, which is referred to us. Okay, so that's we are the man that dealing with all this interact with other elements just now. So how we behave, okay, how we show our the teamwork, how we show our leadership, how we communicate with other team member. So this focus on us. Okay. So as we clear about the human factor just now, so we go deeper on the non-technical skill. Actually, non-technical skill is referred to the central liveware, which is us just now, and how we interact with the other human factor, basically the peripheral liveware you can see here, especially the people around you. So the non-technical skill, talking about the specific behavioral skill of us. Okay, and how we perform it. Okay, I just pop the example from the surgeon, but I guess for non-technical skill, the tema, they're almost similar. So when we talk about non-technical skill, it's about ourselves, about individual itself. So in terms of the situational awareness, about the communication and teamwork, about the decision making, and also about the leadership. So if we look at here, so for the situational awareness, as resuscitator, either us as the managing the airway, or we any procedure like ACLS, ATLS. So we need to aware the situation. So we need to gather information, understanding also the information. And at the same time, on the non-technical scale is also the decision making. So considering option, selecting and communicating option, and also implementing and reviewing decision. This one fall under the cognitive construct. Okay, another component which is interpersonal construct, which is the communication and also the teamwork, which is we can exchange the information, establish a shared understanding, how we coordinate team activities. Okay, and the leadership. Okay, this is very important also, setting and maintaining, supporting others and coping with pressure. This one interpersonal construct. This 4 component is fall under non-technical skill of the individual, which is referred to the central life way just now. Okay, so there is a study look at into the facilitators and barriers of successful airway management. This is the qualitative study being published pre-COVID. So if we look at the theme there, the tema in terms of the successful for facilitators of successful and barrier of successful airway management, the tema mainly discussion about the equipment location and the storage, okay, the teamwork and communication, and also experience and learning for the facilitators. For the barriers, is almost similar tema, which is talk about time and resource limitation, the teamwork and communication, equipment location and storage, experience and learning, as insufficient backup planning and equipment preparation. If you look at here, the teamwork and communication, and also the location is important in terms of determining the successful airway management. So if we somebody called us, for example, Code Blue, we went to we go to other ward, for example. So sometimes we're not familiar with the location. I think the environment is. So sometimes we can see our colleague from NS, if anticipate difficult airway, they came down to our resource, and sometimes they are not familiar with our setup. So that's actually a time that we need to help them, because one of the factor that the barriers of accessibility, the location, unfamiliar with the setting itself. And of course, the teamwork and communication will go further details after this. So I guess this is most of us read about this, a lesson on human factors in airway management, learned from the death of George Washington. So the discussion between the 3 prominent physicians that time in 1799, whereby the late of the first American president, George Washington, complaining of severe throat symptom, and it was treated. But one of the physician suggests to do immediate tracheostomy to secure the airway. But another 2 physician, which is more senior, overruled the proposal, and they said the most likely the George Washington died because acute epiglottitis that proved to be fatal at the end. So one of the physicians that proposed the tracheostomy especially could mention that could have a safe Washington life if they perform early the tracheostomy. So from here, they analyze the human factors of this event that show this, number one, the situational awareness. Okay, this awareness. So they cannot, predict the anticipate the worsening of the Mr. President condition. And we talk about the senior, sometimes the significant resistance, not all senior. I mean, in this case, they give an example. So leadership model was also based on hierarchy instead of competency. So which might have also contributed to Washington death. So these factors, human factors involved. To be specific, because situational awareness and leadership fall under non-technical scale of individual, okay, individual itself. Okay, so what are the most common human factors? So the non-technical scale, I just mix the words. Basically, the non-technical skill leads to error in emergency airway management. Number one is the situation awareness issues. Okay, failure to anticipate difficult airway scenario, and making wrong decision due to lack of situation awareness. As we all know, the airway management is a dynamic process. And once you encounter during presentation, it doesn't mean the presentation is almost similar. It can dynamic, it can change to, more difficult or become more easier. It depends on what kind of cases we deal with. And number two, communication and teamwork failure. So poor communication among team member and lack of closed loop communication. I guess those in the simulation understand about the closed loop communication. And third one is a cognitive overload. Of course, we are in emergency situation. Of course, we are type A personality as emergency. So thinking a lot. And of course, during stressful event, adrenaline pump. So of course, we might, have some cognitive error. So of course, failure to consider all airway management option, and sometimes we fix on a single technique to the exclusion of others. So this is, I think, can overcome with the teamwork, and of course the part of that is the experience of the operator itself. Yeah. The report from JCI again highlighted about the main concern that they produce the error or problem with the patient during airway management in Net 4 report audit. So they found that the main reason is the communication issues. So they found that this communication issue affected the patient safety during resuscitation, specifically to airway management. So they found that this two team, which is the communication and leadership, that leads to this root cause analysis during the mortality during Net 4 audit. Okay. So how to improve for NTS? NTS stands for non-technical skill. How you want to improve this? So the if we look at the system review and meta-analysis, of course, nowadays people talk about the SRMA. If we look at the to improve all these non-technical skill or human factors, basically, they promote the use of simulation intervention, mainly crisis resource management. Crisis resource management, create a scenario, crisis resource management to train emergency and healthcare professional in non-technical skill. So they found that improve the level of knowledge, attitude, self-efficacy, and also non-technical skill performance. Specifically, they focus on the communication, leadership, and also teamwork. So during COVID last time, of course, we everybody concerned about the COVID-19, especially when managing the airway. So human factors in airway management in COVID-19 is the perfect storm. So this published in 2022. But I interested important storm is the teamwork. So the magic bullet for successful in one word, in one word, in managing airway patient, especially in COVID-19, is about teamwork. And interestingly, the author described in his report that the power of simulation. Okay, yeah, the simulation clearly demonstrated by many study, proved by many study that we can, successful managing patient airway when by using this, a simulation technique. And interestingly, by enhancing technical skill and awareness of non-technical pitfall, the simulation also turned out to be a powerful tool to reduce anxiety and to develop resilience. Okay, again, because I highlighted two important themes, which is the teamwork and also the communication. I guess those who join any resuscitation ACLS, the ATLS, I think this word always came out in the facilitators talk about the teamwork. Okay, so we introduced a team member, reminded the individual level of training, allocation the task, discussion the potential problem and highlighting solution, and clarification of team mental model and the airway planning. So the teamwork is vital, especially in managing the airway. And other important term they use here is the sterile cockpit. Basically, it's referred to the communication. So fall under communication. So during intubation time, the team should maintain a sterile cockpit, basically the sterile communication environment. In other words, to minimize the noise, basically. Yeah. So do not disturb much on the operator or intubator when dealing with these difficult airway time. Okay, and only essential team members present. And of course, sometimes we in the emergency department quite difficult sometimes to control in our environment. Semua orang ada kat situ. Okay, so but sometimes we alhamdulillah able to manage. So of course we used to that environment, but in general they said the sterile cockpit or sterile communication is helpful in managing airway patient. So other important point they highlighted is about the cognitive overload and decision making. As you all know, in emergency department we are multitasking, so we see a lot of patients. So that's why cognitive error quite high in the our discipline, specifically the emergency, because of the cognitive overload. So how to overcome this cognitive overload, especially when we're dealing with the resuscitation with a high adrenaline, multitasking, So one of the strategies to mitigate this cognitive overload, which include the use of cognitive aid, for example, algorithm, structured algorithm, okay, either by a visual, a graph, image and sebagainya. But at the end, I think whatever structure algorithm available in front of us, when we see this resuscitate patient, everything become blur. That's why we need our colleague that help us in terms of the more confident, keep us calm, guide us. Of course, you are team leader. We are need to be lead the resuscitation. However, sometimes we need the someone that can help us to calm us, to guide us, especially in high stake condition. Yeah. So, of course, we have been early this year, and we have a case of this, the legal case whereby the our unfortunate, colleagues involved in this not so-called, libel in court, especially our friend in the private hospital managing the airway patient and happened to have the complication. So there's element of human factors also involved during that time. So, so for take-home message, I guess the NTS are the foundation for safe and effective airway management. So we need to prioritize the development of this skill alongside the technical competency. I guess here, I think the member here, participant here, or the expert in managing airway in terms of skill, technical. But then the other important factor that we discussed today is non-technical, which is mainly focusing to the operator itself, how we control ourselves and how we interact with our friends is a very important component also to minimize the error and at the same time to give the best outcome to our patient, especially when we're managing the airway crisis. So all men make mistake, but only wise men learn from their mistake. So I hope I give a justice for this topic, and I welcome any feedback or any comment from others. So thank you, Professor.
Okay, thank you very much, Prof. Ashari. Now, I open if there is any questions, you can ask directly to Prof. Ashari or you can type it in our chat box. Then I can read out for you. I welcome any questions or comments on this particular topic. Tinggi sangat topik ni, Prof.
Tinggi sangat dah. Yes, sir. I
Maybe
think
I can start the ball rolling. Well,
Yeah.
ya, Prof, sila Prof. Prof tanya susah, soalan susah lah.
Prof tanya, Prof
kena
jawab.
tanya expert lah macam ni, kena tanya expert.
Prof
Okay.
tanya, Prof jawab dah.
Okay, I think Prof. Hashari brought up a very interesting topic in terms of the NTS, non-technical skills of airway management. Yeah? Now, in your own experience, what are the common non-technical skill that you think, from your own experience, not from this, but from your own experience, that we should focus our simulation training on? And that's one. The second question is actually, how would you get the buy-in from our colleagues in going through this non-technical skill training? Because a lot of us mainly more focus into technical skill, right? I mean, if you do an airway management, people doesn't want to talk about communication lah, close loop. They more concentrate on the technical skill. So how do you overcome this issue? So thank you.
Susah soalan Prof ni, Syam.
Boleh.
Thank you, Prof. Saya cuba lah, Prof. Maybe others boleh boleh tambah lah kan this So soalan satu tadi berkaitan dengan common non-technical skill, Prof. So my personal experience, I guess for the airway, especially for the airway, salah satu yang common yang saya perasan adalah related to the situation awareness, Prof. So whereby kita sometimes walaupun kita belajar kan about the anticipate difficult airway, sometimes kita underestimate the airway, and sometimes ada juga kita overestimate juga. So overestimate itu susah juga lah. So I think that's the apart from others non-technical skill, the situation awareness. So maybe others have their own opinion lah. So the second related to how to buy in, Prof. Of course, kalau nak ajar, I agree with Prof. Basically, to teach non-technical skill alone, people are not really interested. But then I think the awareness na kot. To begin with, I think the awareness, and we need to incorporate incorporate in our current courses which is a part of technical tu memang kita kena run together with the non-technical skill. At least we alert ataupun create the awareness among the participant. It's like previous we talk about the airway skill, intubate sampai advanced airway dan sebagainya, guna VL, guna bronch dan sebagainya. But that skill can be developed. But in terms of non-technical ni, saya nak buy in pada peringkat awal ni tak boleh alone juga. So we have to incorporate inside the courses, and then at the same time kita create awareness lah. I think that's my opinion lah. Maybe others boleh share, Prof. Ya.
Terima kasih Prof. Syari.
Prof ada jawapan tu, rasa Prof ada jawapan sendiri.
Yeah. Okay, we have a few questions from the chat box. Shiraj mentioned interesting anecdote from Prof. Ashari regarding George Washington. Please allow me to share. So maybe I will invite Shiraj. Maybe you can share yourself, Shiraj.
Yes, please.
Please, Shiraj. Dr. Shiraj. Are you available?
Malu Syam, dia malu.
Malu, tak malu. Apa? Ni ada ni Dr. Shiraj. Yes, are you available?
It's okay, free to nya.
Uh,
Just share your ni. It's okay.
Ada Siraj. Please allow me to share another almost similar case involving a more recent case about a routine tonsillectomy case. The case involves specialists from both ORL and anesthetist team who were, as Prof mentioned, caught up in repeated futile attempts and couldn't get their thoughts together for the use of alternative, although options were available and were prompted to, again highlighting the importance of our non-technical skills. Okay, this is comment from Shiraj. Thank you. Rashidi, Prof, can you share your opinion on the use of thinking or decision-making models in managing difficult airway in a stressful environment, especially for a less experienced healthcare provider? Would it be beneficial? He asked about the thinking or decision-making model. It's a framework model. I also not sure.
So first of all, thank you, the Shiraj and also Dr. Rashidi for question and comment. So I guess for the of course when we are in stressful environment, whatever guideline or algorithm sometimes become blur. So that's why I said earlier. So we need to be trained. Banyakkan simulation, especially related to CRM, crisis resource management. For those yang less experienced healthcare provider, I guess memang need to call for help because if you look at the algorithm, if you follow DAS pun sama, if you encounter any you anticipate difficult airway, the first step is call for help, especially if you are not really familiar with the airway management. But if you are alone, I think by group, whatever it is, the airway, we need to secure airway, either supraglottic or infraglottically approach is have to, because it's a life-saving procedure. And like I mentioned, kena belajar juga lah, kena train how to do surgical airway and others. Ada someone angkat tangan, I think raising.
Ada ke?
Yes, now.
Okay. Next, from Najmi Kamal. Prof, can I ask regarding medical legal in airway? How long does it count if we cannot secure the airway to consider as negligence?
Wow. Thank you, Dr. Najmi. I'm not pretty sure actually how to answer this question. But if we look at the any medical legal cases. I think almost we compare with other medical legal cases. Few model, I can't remember the model. The key point is it's not about time. It's about the standard of our management. If we think that our management is standard already and equivalent to other practitioner, so that basically is not considered negligence. I think it's maybe others can give input. Yeah. Mungkin ada ni.
Any more questions or comment turning to this topic?
Hello, sorry, Isam tadi ada mic problem sikit.
Oh yeah, Shiraz. Yeah.
Oh, okay, please.
Sorry, actually, when I listened to Prof begin this topic and talking about I didn't know I didn't have any idea what he meant by the topic of non-technical skills. But when he started this topic, I quickly remembered one YouTube video that I saw regarding the case of Elaine Bromley lah. Basically, this case, a child, I think teenagers lah, was routinely admitted into a outpatient GP or a specialist ENT clinic some sorts for a routine, I think tonsillectomy, something like that. But then it happens that during the procedure, she developed some complication. They had trouble intubating her, and yang menariknya, this case involved all the specialists. There was an oral specialist involved. There was anesthetist involved. In fact, they have all the equipment also involved. But somehow, especially if you look at the video on YouTube, I shared the link. They were prompted even by the nurses to use other options in intubating this airway or managing the airway, but they were totally cut off. I don't know, something happened that they just couldn't connect the dots when it comes to managing the airway of this unfortunate case of this unfortunate lady lah. So I think just to highlight again the importance of that what Prof mentioned just now, the situational awareness. Sometimes you can get too caught up in the situation and you just cannot think. So that was my just bukan comment lah, just sharing. Terima kasih.
Thank you, Shiraj. That's true. Okay, any more questions or comment?
Hello, Chan from Kuching.
Yes, Dr. Chan.
Oh, Dr. Chan from
Yeah, thank you very much listening to all you. Just a little bit of my concern nowadays. People may, they take intubation very lightly, especially from the junior folks. And then looking at the medical legal and the UK, I'm sure that you all know UK. They're very particular who can intubate. So I don't know, looking at the medical situations, medical legal situations, and also the attitude of younger folks doing intubation. Definitely they're successful a lot, but with time goes by, there may be complacence of these advanced airway intubations. A lot of time you talk to them and say, I'm very successful. I don't have to worry too much. But for us as a senior folks, we say that this is zero. We have to perform zero mistake.
Yeah.
So I don't know what's your comment. Looking at it, we also a bit concerned too much about UK, very conservative. But at the same time, looking at the medical legal perspective, I don't know. I think maybe we need to be, stringent on who can intubate patients. Yeah, that's my view with the medical legal situation after 2 cases of multi-million compensation. So I don't know, open for a discussion.
Okay. Thank you, Dr. Chan. I think Dr. Chan brought up very important point in the era of medical legal nowadays. And so a lawyer also looking for us. I'm not sure ada lawyer kat sini. Boleh tak? So the
If I may share something on
Yeah,
the
Prof.
medical legal aspect, well, this is my opinion. I don't think that we should have like apa, the belief of that only certain people can intubate. I think that that should not be it, because if we propose that kind of that kind of thinking, then one day people will come to ED and everybody say I cannot intubate. But I think we should go on the elements of credentialing the people on who can intubate. I think that's more important. So basically, because all this while, when people pass their EP and everything, we expect them, okay, these people have done a logbook of 50, so they definitely can intubate. But I think what they did in the States, in the US, even as simple as blood taking pun dia ada credentialing. Dia kena dapat credentialing dulu. Baru boleh dia, then only he or she can perform that procedure. So same goes with Airway. I think that is important. I think what Dr. Chan brought up is actually important point, a valid point, in the sense that we should basically go all out in credentialing the procedures, all the procedures that what people can do. And basically hospitals or department per se should basically look into that. Okay, only those who are credentialed to perform this procedure are allowed to do. I think that's the thing. So it's not like macam, oh, okay, if I can, I want to work, but I don't want to be credentialed, so I don't have to do any procedure. I think that's the wrong attitude. The right attitude is actually, if you want to work, you have to have a certain, there's certain procedure that you are credentialed to perform. If you don't have that thing, you cannot work here. Something like that, that kind of thing. And not only that, because again, in some of the state of the United States, some of the state, they have this re-credentialing. After 3-4 years, they have this re-credentialing. People have something like the MOCA, or people have something the MOCI, and maintenance of certification in emergency, something, or maintenance of certification in anesthesia. So they are courses which is simulation-based course to ensure that these people are credentialed to do. If you call yourself EP, there are certain things that you need to able to perform lah. Basically, emergency procedures lah. That is my opinion on this thing lah. Thank you.
Okay, thank you. Prof also comment in the chat box, if I may suggest, maybe when we creating a scenario for training, we should purposely include in the LO, learning objective, on how to call for help. So the LO is to call for help, like the AHRQ team steps training models. So participants should actually try it out on how to call for help. What do you think? Maybe Professor Shari want to respond to that?
Okay. Sorry, Prof, saya not familiar with this term, AHRQ.
Step training model.
Yeah, step training model.
This is just an example, but should we put call for help as an LO in our simulation training?
Okay. So LO mean the learning outcome, is it?
Learning outcome or objective, yeah.
I guess, yeah, in terms of airway management per se, and we're dealing with the, for example, difficult case, I guess the call for help is vital, because it's sometimes not everybody perfect, not everybody can boleh perform kan. So I'm not sure, Prof. So saya harap boleh, pada saya penting lah. I think that's a call for help. Yeah.
Right. And Prof. Tiru also mentioned that using a common technique for training like ISBA would help. Yep, very agree with you. Okay, Prof. Zaleha?
Can I just add?
Yeah, sure.
Yeah, because I think there are a lot of barriers for our junior doctors to call for help. Even in my practice, I've seen sometimes they hesitate because they're afraid to call early. And then when they call, how they transfer the information, because time is of essence. That's why we train doctors on airway assessment and all that, isn't it? To be able to identify a potential airway problem and call for help early. So those are things I think if we do the simulation training, we should include, because I find in my own practice with students, they don't call for help early. That is I have to emphasize and re-emphasize, you know. So sometimes junior doctors say, if I call now, what if I get scolded? You know,
Yeah.
I should have called, I would have tried it a few times. You know, that kind of barriers might prevent people from calling early. So those kind of cultures need some work, I think.
This is what we call lack of situational awareness. Yeah.
Yeah.
Yeah. Okay. Next, Prof. Zah. Yes, please.
Yes, thank you very much, Prof. Hisham, and thank you, Prof. Ashari, for a very enlightening talk just now. I really enjoyed it. All those examples that you quoted, the cognitive load, overload, and things like that. And I would like to actually echo what some of my friends have already highlighted in view of the fact that this morning actually I conducted a workshop on team steps for my staff here in UKM. Quite a number of nurses attended actually, and also a few doctors. And I think it is very important for us to bring up all these non-technical skills, the principles of which is actually very much enshrined within the Team Steps AHRQ principles. And basically, as Prof. Thiru also pointed out, and Prof. Ismail mentioned the Team Steps training model as well, in equipping our subordinates, particularly the junior doctors, the nurses, how to be more assertive when they try to alert the doctors to do the right thing. And I think Dr. Shiraj also pointed out just now in the case that he was quoting as an example, how a few nurses tried to alert the doctors. But I assume that, you know, those words fell on deaf ears. So the tools that are there for people to use in the Team Steps training could actually prove to be useful in overcoming some of the inhibitions that we have, particularly those people in the downline, you know, the junior ones, in trying to correct things when the seniors are not really doing what they should be doing. Thank you.
Thank you, Prof. Zah, for your comment. Okay, I think that's it, Prof. Ashari. Do you have any last word?
Thank you so much for the comment. Also, I also learned definitely from all of us here. So thank you again for this peluang lah, Prof. Sham. Thank you.
Yeah. All right. Thank you, Prof. Ashari, for your interesting and a wonderful presentation. Thank you, everyone, for your time. So before leaving, please scan the QR code to obtain your certificates. Thank you very much. See you all again, probably next month.
Thank you. Bye. Assalamualaikum.
Waalaikumsalam warahmatullahi.